Globally, 2.6 million end-stage kidney disease patients are reliant on hemodialysis as a form of kidney replacement therapy. In hemodialysis, the body's blood is filtered externally and excess waste products and excess water are removed. A key component to enable hemodialysis is that we can provide sufficient flow to and from the dialysis machine to allow efficient dialysis. Typically, this is around 350 milliliters of blood per minute. The blood vessels in the arm are superficial and allow easy cannulation, except they do not provide sufficient flow. So what the current standard of treatment is to create what's called an arteriovenous fistula, or AVF for short. This is a surgical connection between a vein and an artery, a high-pressure artery and a low-pressure vein, which essentially creates a short circuit for the blood. The blood can then bypass the smaller blood vessels in, for example, the hand, and this drastically increases the flow. Typically, this is at least 600, but in some cases it can be up to 3 liters per minute. This sufficient blood flow rate allows dialysis to be performed in usually 3 sessions of 4 hours per week. Although the AVF is currently the gold standard of treatment, it does introduce complications, because what we essentially do in the blood vessels, we have a quietly flowing river in a normal setting, then we introduce this bifurcation, and what we get is a very high flow and turbulent condition, which you could probably best compare to a whitewater rapids. This is not a natural condition for the blood to flow through the veins, and the result is that the blood vessel itself starts to remodel. This results in a very poor access patency. The AVF itself starts to fail due to inward remodeling as a result of these altered flow conditions. Patients typically require 1.5 surgical interventions per year just to keep the vascular access functional. This is paired with a high cardiac burden due to the increased flow through these vessels. Patients often suffer from Steele syndrome or distal ischemia, in which insufficient blood flows to the hand and tissue starts to die. The blood vessels can expand tremendously and cause aneurysms, which can eventually burst. And during cannulation, the compression time due to the removal of the cannulae can take very long due to the arterial pressure in the vein. And this is where we see something interesting, because patients have this high flow vascular access 24 hours a day, 7 days per week, which is essentially the cause of all complications. However, they only require dialysis during 3 sessions of 4 hours per week. This is a big discrepancy, and this is exactly what we're trying to solve. We called it the dynamic AVF. What we do is we implant the device between a vein and the artery in the arm. We create a similar AVF, but one that we can open and close. In doing so, we only have the high flow during dialysis sessions, and we normalize the circulation when the patient leaves. With a magnetic transmission interface, which you can see in the blue and the white on the right on the screen, we allow non-invasive control of the AVF. This is done through magnets. By removing the core issue of vascular access for the majority of the time, we should drastically reduce the complication rate.